The bottom line is, for me, is that the baseline, the current system of having a private healthcare that serves the few but getting a lot of money and a lot of funding doesn't work. One of the most critical area, which we had already started even prior elections, was for our clinics to be rendered 24 hours. That's why you would see that for these past 100 days, we have been able to make intervention in Mashamba Clinic. I was there campaigning at a Mashamba Clinic, and this was a question which I was asked, and I made a commitment, and indeed I had to keep that particular promise. And against all odds, the clinic, it was very difficult to get it running 24 hours, but don't ask us why. But we've got capable men and women in this department, led by our HOD, Dr. Mhlongo. We're able to make sure Mashamba Clinic is the first one to render 24-hour service, and it is rendering 24-hour service, and everything is going on smoothly.
Before we were working standby, taking calls. Patients were coming for emergencies at 18 hours, then the security will come and call us. We go and attend patient any cases. But the MEC came on the 30th of June to launch 24-hour service, and on the 1st of July, we started operating 24-hour service. And the community of Mashamba and the surrounding villages are benefiting from our 24-hour service because they come at any time and get the service.
We've got support from the traditional council. That's why even the crime has not been reported, and our nurses, our staff has not been. We also have been in Marapong, in Lephalale, where we activated.
We have started the health center in March 2017, and we have only rendered 12-hour service by that time. But there was a big need for this community to have a 24-hour service because they didn't have any access to health service during the night. But from the 7th of July, this year 2019, our MEC Dr Phophi Ramathuba came and opened this facility for 24 hours. And now the community is having access to care, to health care, of all the primary healthcare services, 24 hours a day.
We had a clinic that was built by the mine, a state-of-the-art clinic, Skuruwe, in Waterberg, Mogalakwena. That clinic was handed over to us, but we could not open it for 24 hours. We could not even open it for the clinic to function while you have a state-of-art building in that particular area, and that it was going to be prone to vandalism. We made commitment that that clinic is going to work in the 6th administration. It will be one of the first clinic to be operated to work, and we did kept our promise. We managed to get staff also from other areas to go and assist, and the clinic is now functioning, it's rendering services. We also made a commitment with a partnership of TAC. TAC came here to my office complaining about the infrastructure in Kramatat in 2018. And they've raised those sharply. I went to visit, and indeed there was no even ablution facility. It was really a nightmare. And where the nurses were working, the environment was not conducive. We had to be innovative because we did not have enough resources to can do that. So that's why our innovation has assisted us to go back to the old Giyani hospital. Because remember, Kramatat Clinic, when it was built, it was mainly for few families of white people who were working in Giyani at that time. So when you now open it to a number of villages around there, you had to deal with the infrastructure. And for all these years, we've not been able to deal with the infrastructure. So we are proud of our team because in the first 100 days, this is one of the clinics that we managed to complete its renovation, and everybody now is happy. The dignity, the dignity of the patient. When you are sick, honestly, you want to be examined, being you and the professional who is examining you, not in the full view of everybody else. So we've been able to deal with that, with the clinics that are running now 24 hours. Now, one of the areas which we have been concerned as a department is that The health system in this country has become more of a curative system. That's why we are not winning. Because once you wait for people to be sick and they come to your facility, at that time it's very expensive for you to deal with them. So while our main focus, you can hear it's strengthening a primary healthcare services, we also at the same time to say, where is our preventative healthcare? And we realize that food, what we eat, it's what is causing a lot of problems that we see in our almost all. Whether you go to your cancer patients, if you go deeper and do your research, it's related to what we're eating, the processed foods, your Viennas, your Palonis, your all those things. And until we deal with that, if we want to live a longer and a healthier life, let's go back to the basics. So food is very critical. Whether you're talking about diabetes, you can reverse it by just changing your diet. You can reverse your hypertension, your high blood pressure. You can reverse your hypercholesteremia if you've got high cholesterol by just dealing with the food. So we felt for the public to begin to follow us and appreciate what we want to do, let's start ourselves in-house. What are our patients eating? I mean, it has been a problem. We started by insourcing our kitchens during the 5th administration. Now, after insourcing the kitchen and employ the young graduate, most of them, you find they've done food service aids in their universities and their TVET colleges, but they are unemployed. But the people that are working in our kitchens would not necessarily have that qualification. Because whether we like it or not, people can say we are being unfair. We want everybody to go to school. Not everybody is qualified to cook patient food. I'm not qualified to do that. I might be a doctor and I might know that you must have low salt intake, but I don't know which type of salt. I can think aromat is the best. I've learned recently that you can't be having such preservatives that you are using. Use the ordinary salt that you have, which has got iodine. So you will know that when you are trained in that particular field. So that's why we were saying, even now when we advertise posts for food service, people who are going to cook in our kitchen, there are people who are graduates, who have graduated in that particular field. We are beginning to professionalize our public service. You can't have so many unemployed graduates, but still at the same time, you still use grade 12 as a minimum requirement in such category. In your admin clerks, in all those, you can't. You've got to start using a diploma and a degree as your minimum requirement if you want to deal with this unemployment. And at the same time, if you want to say we're moving towards a 4th industrial revolution, you need people who can use the computer. Some of our people can't even move a mouse of a computer, and you want them to. So we are not against anybody, but we are saying in this day and age, government has provided a platform for people to go to school. So graduates will be our priorities. So what we were able to do in this first 100 days was something that I've been long waiting for, to launch an 8-day cycle menu. This is a menu that shows what it's standardized. When I move to a hospital, I know if it's day 7, they must cook this and this and that. And when you do monitoring, you monitor based on that particular menu. And now after launching it, we cascade it down to districts and hospitals. If you can see hospitals, including Musina Hospital, by the way, that has been on the news for wrong reason. It's shaping up. We visited them. We gave them, we read them the Riot Act, what we expect to happen. And I was proud to say they've already launched their own 8-day cycle menu. They are shaping up, and you will see things will be different very soon. So all our hospitals, we don't expect people to be eating what used to be served in the past, a hard-boiled egg with pap. When someone, you see, when you are sick, firstly, the condition itself makes you not to be having appetite. Illness itself, you lose appetite. The medication that we're giving our patients, also its side effects, it's you don't have appetite. And then on top of it, if we give you medication which will make you to lose appetite, and then we then give you a food that is not a plate that's not attractive, we're killing you. While worse, for you to take medication, you need food. So food for us is medicine. So that's why we launched this, and it's going on. Recently, we went to, in this 100 days of ours, Seshego Hospital. When you see the congestion of Seshego Hospital, you are going to cry tears. The population of Seshego is growing. Every day when you come, new discerning, there is that, but the hospital is not growing. Population is growing, burden of disease is growing, but the hospitals, the infrastructure is not growing. So people get surprised while you'll find our nurses having to improvise and put mattresses for other people to sleep on the floor. It's mainly because we're having a population growth, but our facilities are not growing and the diseases are growing and we are not meeting the particular demand. So we put investment on getting some of the wards that have not been unused, the spaces that are not used, we then go into them and make intervention. Now we've got a 21 bed neonatology unit just for those little premature babies who are now currently have been in all these years being transferred to Mankweng. Mankweng, it really cannot cope anymore. So now we've got that one in Seshego, where in even hospitals like Nobel, F Nobel and Helen Franz and Zebediel will be able to refer to Seshego Hospital when you are having that. You don't have to call to Mankweng. And pediatricians in Mankweng Hospital are able to support and visit that unit and see those little babies there. So you see now, you've got only one specialist when they go there to visit a Seshego Hospital. They are not only seeing patients, they are also impacting skills with our medical officer. They are also teaching, they are also training. So we have that neonatology that has been completed. Of course, very soon, in our next 100 days, now that we are finishing this current 100 days, we will be opening the first and ever cardiothoracic unit in Mankweng Hospital. Remember, we've been doing the first open heart surgery in 21 years on the 18th of April, and we continue. People thought it was election. It was not an election, it was saving lives. We've been able to do, I think, by now probably we're at 20, but we need a proper unit which is dedicated for that. So we've been able to identify a space, we've put the equipment, now we're at 90% completion. So that unit will be run by Professor Mhlala. The good news is that he has been able to take up an offer to agree to head that unit and help us to build. And the first thing that he did was to make sure he put this infrastructure together with the clinical director, Dr. Moila. So we can tell you that in terms of infrastructure, we will be there. Very soon, we've already completed the records unit in Letaba Hospital that we are supposed to officially open is now functioning, because we allow it so that if there's any problems from the contractor, they will be able to pick it up and we report. We will be also moving to Dr. CN Patudi also. We have recently completed, we are just finishing it. You will see it has been finished within the 100 days that we promised. Butlokwa Hospital. That was one hospital that never made us to sleep peacefully. We made intervention. We brought the young man to be a new CEO in that hospital within his own 100 days, which was overlapping with my 100 days. We've been able to complete renovation of a theater in maternity. The theater was just built and it was sitting there accumulating dust. Because we didn't have proper visionaries who were leading that hospital. So we've done that. The theater, it's working. Now, maternity or pregnant women are no longer competing with other patients. You know, you've got somebody who's got a general condition who needs to be done a reduction of a bone. And then at the same time, there's a woman who needs to deliver. So the mother and the child's life becomes at risk while waiting for the other one. So now we're safe. The maternity, it's right. The theater, it's right in maternity itself. So when you have got a CPD, you just wheel the woman just less than 100 meters. Just wheel the woman to theater and take out the baby, and the mother and the baby are safe, because women and children remain my priority. And that one I will not compromise to anyone who says, even my budget must be skewed to women. You will see very soon. We are in Mukopani now. We're going to close the maternity in Mukopani because we want to have a major project of renovating it and building it to be one of the state of the art. We will be coupling it with Fortrekker and making sure that we have got those center of excellence, because there in Mukopani, we need to have a center of excellence, a trauma unit. We must also have a center of excellence in maternal. So Mukopani and Fortrekker must begin. They are 8 kilometers apart. So they must share this particular units that we're looking at. And of course, human resource continue to remain our challenge as a province. When you look at the issues of revenue collections. We've been able to improve in the past financial year, and we've been able to be given an incentive by Treasury to say, given even the shortage of staff with all the challenges, but we've been able to collect that. So now an incentive fund was given to us. That's why yesterday, which formed part of our 100 days, we've been able to appoint 40 new registered clerk, distribute across our provinces. Their main role, they know very well. Yesterday they were given marching order. When you are appointed in the Department of Health, you will be welcomed by me, because I want you to know what we want to happen. You need to understand my vision. You can't pick it up on a newspaper or on the street. You must hear it from myself. We start on a clean slate, so that even when things don't go right, when we say thank you, you think the Department of Health is not a good employer for you, we would have done our part of talking to you. We have also employed, I think, around 35 malaria members of malaria team. You'll remember also in terms of malaria, last year with a shortage of all the staff, we've been able to fumigate around 922,000 house units. And from those areas, coupling mainly in Mopani and Bembe district, it has been able to assist us to reduce the malaria cases from the previous financial year of 18,777 to just a mere 6,606. And that, if people of Limpopo doesn't see it as an achievement, that's a huge achievement. To cut down malaria, meaning when you cut down those patients, it means you are cutting down on your drugs that you are using. So you are cutting down on the expenditure on pharmaceutical. You are cutting down on hospitalization, which does not only talk of medicine, it talks of linen, it talks of staff that must look after you. So the malaria team is very critical. People do not understand. When we say we are a Department of Health, ours is to prevent disease. We don't wait to treat them. So that malaria team is going to strengthen that work. And remember also, in terms of the death rate, mortality, we had around 160 mortality in the previous year, and in the last year, while 38 is a huge number, but if you look at cutting it from 160 to 38, more than 76% cut the death mortality rate, which we have been able to improve without the staff. So I was saying to them, now that we have appointed you, we want to see the elimination of malaria happening sooner than the target that we've been provided by the WHO. So we are working on that. We did not only appointed those two, we have also appointed quite a number of medical specialists. We have already appointed our urogynecologist. He's back, Dr. Moaba. Currently, the women with all the challenges who can't even smile or laugh at a funeral, because when you laugh, you just pee for yourself. Just to simplify you, to say these are critical specialists that our people who can't afford will, you can't laugh, you will always be peeing on yourself. We've seen a lot of child marriages, people who have kids at the very age, teenage pregnancy. Some of them, the complications becomes those things. So he will be there. He will be making sure that he's able to provide intervention on rural women, because the aim for us is to make sure those who previously cannot access healthcare are able to access. So Dr. Moaba is there, and he didn't only come alone. He came with his professors from the University of Cape Town to say they've now established, they're partnering with us. We'll be taking some of our registrars to go to Cape Town. We're now opening an infertility clinic in Mangweng. For me and you who can afford, when we can't have babies, we are able to go and do all the what we can. Sometimes you can't give birth just because your tubes are blocked, because at some stage you had a pelvic inflammatory disease that was not treated and nothing happened. So simple stuff which is making a woman to lose a marital home because of that. You get divorced, you called names just because of that. So every woman needs that joy of holding a baby. It should be a choice, especially if really you can't afford. So that infertility clinic will be able to see women in Limpopo also accessing services that could not be. We've appointed Dr. Nichiongo. We've been all over speaking about the great work that he has started, that our women, October, will be going through to the breast cancer month. Now our women will no longer be afraid to come and be done mastectomies, because they know after mastectomy, they will be able to get a reconstruction of their breast. This is something that can happen to me and you. And sometimes what is so sad is that me and you who can afford go for this plastic surgeon to lift our breast or reduce for cosmetic reasons. So this one, we are opening it not for cosmetic reasons, for therapy, so that women don't default. So we are expecting a lot of women to come and be done all those tests. So of course, as usual, we continue with our campaign of breastfeeding, so that women can breastfeed everywhere where they are. We started our Women's Month by launching the breastfeeding campaign. To say, last year we launched our Mama Albertina Sisulu breastfeeding room in this department, so that it starts at home. Charity begins here. Our employees who have got small babies, they have a room that they can go and breastfeed. So this year we said, let's go to our biggest hospital in the province. We launched one, Mama Albertina Sisulu breastfeeding room in Pietersburg Hospital. We're expecting to roll them out throughout our provinces. You'll remember the other year we launched a breast milk bank. So because you see, women and the health for me are quite critical. We continue eradicating the backlog of surgical backlog. We've just completed our another litima. This time around, we broke a record. The total number of patients that were done were 110 in one weekend. Specialists getting into theater from Friday evening and going out of theater on Sunday at 1 o'clock. Coming as volunteers, coming without asking me to pay them, but just to say, for the love of medicine and for the love of our people, we can't expect people to be disabled when it's something that I've been trained as a black orthopedic surgeon. I know I'm now working in Free State, University of Free State, or I'm working in Wits or Pretoria, but Limpopo is still my home province. And I will come, MEC, when you say to Mamina, I'm available. They've done that together with our internal team. We've been able to clear that backlog. But of course, it's difficult to clear the backlog, because when you clear it today, tomorrow, the same weekend, immediately when we were excited to say 110 is cleared, then while they were busy in theater clearing, another accident is happening. So, but the other intervention that we continue to make within these 100 days was to provide leadership in our hospital, because until we get it right with our hospital leaders and get people with the energy, we're not going to win. So we did make intervention in Pietersburg. You can see there is life in Pietersburg. You can really see. We've got a new CEO. He's not old, but also at the same time, he's well knowledgeable, hardworking. He doesn't believe in sitting in the office. He believes in being where the patients are. You don't want a CEO who will be told by the MEC that there's a crisis in your hospital. You must tell the MEC. So if you are a CEO and you are told by me that there's a problem, or by the HOD, then I think you are in the wrong place. You rather leave that office before we come and make that. We've also made intervention in F Nobel Hospital. We are hoping a lot of work is going to happen. Of course, there are some setbacks which we must talk about. The setbacks still remain, that our security in our facility. For instance, the Hamocha Clinic, wherein you are running it 24 hours, but now the thugs just come in and start to terrorize everybody. And I think, Vembe, we have discussed with the MEC for community safety and transport, so that how do we zoom in Vembe and assist in dealing with that, because that it becomes a community problem. It's no longer our problem. Security in our hospitals, it's something that you can't really predict. If I'm to give an example, in the recent Pietersburg Hospital, a renal patient, the point is, we as a caring government, we know that when you are coming for renal dialysis, you have to come 3 times a week. So when you are coming 3 times a week, will you be able to have transport to come? Many of our people can't afford. So also, if we say go and stay in Chilizini overnight, for you to have transport to go to sleep in Chilizini, you don't have. Secondly, do we have enough beds to can let you sleep overnight in Chilizini when there are people who are sick who need those beds? We don't have. So what do? We say, let's agree and say we will go and meet our patients halfway and pick them at home. So it's our ambulances, it's our PPT that are picking patients at home. Are our drivers trained to search? No. Those ones are EMS personnel. It's not their job to search. So they will come and pick you up and you will get into the hospital. When you get to the hospital, securities have been told at no certain terms are you going to search ambulances. Because if we start to allow that situation, securities are not trained like us as a health professional. They're going to stop every ambulance with a priority 1 patient with a head injury. They will start to be searching that patient when that patient could be seen and be resuscitated, and the patient will die. So for us, I always tell you, the mistakes that we do in health, you can't reverse them. So that's why we are always extra careful in what we are doing. So when the person access a facility with a card, it becomes another thing. That's what I'm saying. Security in our facility does not require the Department of Health only to look into. It requires all of us to be involved. So that's one of the setback. Also the other challenge still is the one on the human resources. While we still have the young unemployed community service who wants to be absorbed, while at the same time we're spending 74% of our budget just on compensation and remaining with 26%. So if you are saying I must absorb everybody without getting any new money, that simple means I'm going to take that 26% and appoint everybody else, and everybody else will come and sit in the department. There won't be medicine, there won't be equipment, there won't be infrastructure maintenance, there won't be anything, because even at the moment I'm struggling with that 26%. So that's what we always say. Our people must understand, to say we are trying to come to speaking with a treasury, national treasury, to say invest in health. When you invest in your health, you are investing in your country. You can talk about job creation, you can talk about bringing investors in whatever. What will they come here to do? Where will they get the workforce if everybody is sick and everybody is not being looked after? So you need a healthy nation for you to be able to invest in. And then of course medical equipment, we are buying a lot of them. You have seen that for instance, Letaba Hospital just received their 2 anesthetic machines. Their theater now, there won't be a reason why cases can't be done because there are no anesthetic machine. They've also received their 2 ventilators for neonates, for the little babies. We've seen that the unit that we open in Sishiru has got new equipment that are there, and we are receiving them. We've seen all our regional hospitals receiving C-arms. They are now all over. That's why we're able to even do orthopedic cases even in areas that we could not do, because now we've got C-arms. We're waiting now. Our CT scans are in the country. According to the HOD, they are in the country. Now all we were waiting is for the first time in this province that you will have all our regional hospitals, all our regions having a CT scan, so that no patient will have to leave Sekororo to come here just to be done a scan and go back, or come here and find the scan is not working, can't be operated. So by the time the patient we have decided to transfer, the patient will be in line with the 4th industrial revolution. Scan will be done in Letaba Hospital, Chiridzini, Mupkopan, and they will be interpreted here in Pietersburg, where the radiologist will be. And after interpreting them here, the report will go back. It saves us cost of traveling of our patient. It saves us a lot of money when you look at that. But also, the services will be going to the people. There's still a lot to be done in this department. And we are all doing all this for us to prepare ourselves for the readiness on NHI. Your question will be, are we ready for NHI? We think we can't. It's an issue of a chicken and egg, which come first. We're saying give us that money which you are spending more on the private sector. Limpopo, 91% of its populations are dependent on public health. Less than 9%, the one that has got private medical aid coverage. And come now the month of June, even my own colleagues, their medical aid is exhausted. They are calling me, say, hey, we are sick, can you make intervention, get us special and all that. So that thing, it's not sustainable. The private health care is not sustainable. So we need to look into this particular NHI with, when we criticize, let's criticize it with the hope that we want to improve it. So people are just criticizing the NHI without giving us alternative. The bottom line is, for me, is that the baseline, the current system of having a private healthcare that serves the few but getting a lot of money and a lot of funding doesn't work. The current public healthcare system has got its own challenge of quality. The reason we can't meet those quality, the reason we can't build Chiridzini and build Siloam is because there's no money. Give us that 150 billion as health in the country. we will turn around the infrastructure. We do have the capacity, we do have the skills, we've got all the professionals. We will work and turn this system around. When you are appointed in the Department of Health, you will be welcomed by me, because I want you to know what we want to happen. You need to understand my vision. You can't pick it up on a newspaper or on the street. You must hear it from myself. We start on a clean slate, so that even when things don't go right, when we say thank you, you think the Department of Health is not a good employer for you, we would have done our part of talking to you.